First of all, I tried to introduce a few background information about the Polish reform and the Poland as a country, and then I smoothly moved to the our project. So let's start. Since the introduction of universal health insurance in Poland in 1999, there have been several reforms of the production, delivery, and management of the health system aimed at protecting and improving the health status of Polish citizens. The initial results of the reforms have been promising. In many respects, compared to other countries that joined the EU around the same time as Poland, the health system performed quite effectively and delivered service at a reasonable costs. Okay, I'm sorry, I've got a problem with move the slides. Now, thank you. The social health insurance system provides access to a broad scope of benefits, and mortality from preventable and treatable causes started to decrease over the years, while average life expectancy increased by 8 years between 1999 and 2019. Per capita health spendings went up from $238,000 in 2000 year to $2,289 in 2018, respectively, an increasing of 860%. As a percentage of GDP, health spendings increased from 5 to 3% to 6.5% during the period. However, the widespread reforms were not deep enough and the increase in resources not high enough to resolve many of the structural and systemic challenges embedded in the health sector. Consequently, healthcare governance has remained fragmented. The availability of financial resources in the health sector increased in recent years as the Polish economy grew and health spendings accounted for a large share of the GDP, but relatively to EU average of 9.3% of GDP in 2008, Poland's health sectors receive only 6.5% of the country's GDP in the same year. Inefficient use of available resources further exacerbates the situation, with health spendings being heavily skewed toward expensive hospital care. As you see at the pie chart, it's almost 50% of healthcare services. As a result of the unresolved fragmentation and limited financial resources, there are several shortage of health workers and waiting times are longer for many services provided by specialists. The Polish health system does not compare favorably with the rest of EU in a range of respects. Almost 72% of its healthcare spending came from public sources, a lower share than the average of EU countries, where it's 79%. Life expectancy at birth has increased markedly in the last 2 decades, but remains 3 years lower than the EU average. Unmet medical needs are higher than the average of the EU, mainly due to long waiting times. Fewer Poles reported being in good health compared to citizens of the EU countries. In 2017, a law was passed that strengthened the coordination of primary health care by introducing multidisciplinary primary care teams to coordinate care pathways, including post-hospital treatment and rehabilitation. In 2008, the National Health Fund began to pilot test this approach in the integrated primary health care called PHC+. Designed to be a purposeful collaboration between the patient's family doctor and other primary health care providers such as nurse, education specialists, nutritionists, care coordinators, and sometimes specialist care doctors, PHC Plus aim to enrich patients' experience and enhance quality of care, but decentralization competences to the lower effective levels and by encouraging open communication between the medical practitioners, the patient, and their families. The PHC Plus pilot program was conceived as a way to step up the coordination of care in a bid to increase patient satisfaction, enhance the quality of care, increase access to services, overcome fragmentation in the delivery of care, enrich people's care experience, and improve care outcomes. Organized around the health needs of individuals and their families, the pilot is based on the expectation that integrated care at the primary health care level will help to overcome the lingering unresolved issues in the health system. This slide, you see that our schedule for the implementation, the first stage, where we prepare the models and the starting point, the November 2017, when the preparation to piloting phase was started, and September 2021, when the evaluation stage was started, and now we have a final report, a final conference in December 2021, when we conclude the results of pilot project and prepare to system implementation. But how is the this pilot model? The expanded primary healthcare model of PHC Plus covers the original scope of services delivered in PHC, but also offers a range of additional services such as outpatient specialist care and ambulatory physical therapy. In addition, PHC Plus facilities provide participants with health checkups and access to a range of disease management programs. It also offers a patient access to a broad range of competences than the basis primary health care team, which consists of general practitioners, nurse, midwife, and in some cases, physician therapists. Another innovation was the introduction of a care coordinator in each PHC Plus facilities to support PHC Plus patients. Model covers all patients age 18 plus registered in selected 27 PHC clinics facilities, which was chosen to pilot, and covers over 300,000 patients. Patients aged 20-65 were subject to health checkups and disease prevention program. It was first model intervention that was prepared in this model. The patient age 8 plus with 11 selected chronic disease were assigned to the disease management program, which was the second group of interventions included in the model. The health checkups program offers in the PHC Plus facilities involved health visits and a set of diagnostic tests aimed at stratifying the population into one of the 4 groups: A fundamental goal of the health checkups visit was to identify patient risk factors and refer them to receive health education visits aimed at strengthening their health management skills and their engagement in their own treatment process. The health checkup program could be carried out as in a basic or extended manner, depending on the scope of diagnostic test to be carried out. The program, the second group of intervention disease management programs was set up for a range of chronic disease. I mentioned it was 11. Enrolled patients who qualified based on their health checkups or on the medical staff's knowledge for the health of medical records. Patients in each disease-specific program received care that was coordinated at their PhD facility, as well as specialist consultants, physiotherapists, and health education. The diagnostics care pathways for each of the 11 chronic conditions determined which interviews were chosen, and patients in each disease management program receive all required services and support at the PhD level without the need of additional specialists based on referral. PhD facilities was selected to the pilot represent all the region of Poland. I mentioned it was 47 facilities. Also, they represent urban and rural areas, and were divided into three types of according to capacity, and I mean number of inhabitants. It was a small, medium, and large facilities. The key role in the implementation in this pilot project was communication and all the stakeholders level. Patients, medical staff, managers, authorities, administration, and the key components is the communication was divided into three groups. Training, mainly for the medical staff. It was for facilities. Direct support was general information about the project and also for the patients, and information from the monitoring and evaluation phase. Training mainly was a workshop, learnings, meetings with providers where we when they shared the information and share about the program, were also guidelines, standards, book, also study materials to support the facilities to organize the coordinated care inside the facility. As a direct support, it was also ongoing coaching, health application for the patients, supporting them in self-management in the disease management program. It was also a website where we shared the needed information for all the stakeholders. There were also a fax, social media information, for example, Facebook, also conference, teleconference, webinars. We also prepare digital documents which support the organization and share the information between the patient and facilities, and between me with the staff, and to organize proper coordination. The monitoring evaluation communication, it was results of the surveys, information about the from the data collection. We provide also monitoring visits at the medical facilities, and almost all the channels of communication with all the stakeholders. Monitoring and evaluation, of course, is the third very important area of the pilot project. We try to answer the four important questions. Have the patient outcome improved? Have the patient experience with chronic care improved? Has the disintegration of service provision reduced, or has the integration of service reduced cost of care? For the monitoring, we use qualitative and quantitative data collections from surveys like qualitative PROM, and PAM survey, also a personal satisfaction survey, qualitative data collection, which we about the utilization of the health services. We also introduced like a collaboration with the Sirocco exchange program. We also piloting the monitoring assessing program. The 40 entities was interviewed with this tool. It was about 220 telephone interviews in 40 entities. I skip maybe this because this is the timelines and the schedule of the monitoring and evaluation process. It's also, of course, important, but I think you can find it later. What was the findings from the piloting program for the next step, which is implementation to the healthcare system? Findings from the patient experience, the very important was that we observed shortage waiting time for selected specialized services. We also observed improved self-perceived health in selected chronic disease. Better experience with the coordination care. The fragmentation of care index was improved. So it's the goal of the fragmentation is achieved. Better experience with the care process. From the disease management program, so manage the disease. Twice as many active patients using the PHC services than in the previous years. Enhanced checkups, the key tool in were the key tool in prevention. Disease management program use only 12% of the dedicated population age 18 plus, and within the 11 chosen diseases. Findings from the capability, which was more important. The capacity of PHC facilities varied considerably. Teamwork between PHC personnel and external specialist physicians, outsiders, needs to be improved. Medical personnel reported that the main problem they encountered was an inadequately prepared IT system. PHC facility managers reported that insufficient use of IT tools and no access to data beyond each provider. Also reported insufficient capacity building of PHC plus facilities and a little knowledge exchange among them. Limited proactive population management by the PHC plus facilities. There was not enough teamwork with PHC plus facilities. What was the lesson learned from this piloting and these findings? We find that some successful implementation is what we prepare now of integrated course require teamwork, ability, skills inside and outside the health facilities, e-health tools to allow for sharing of medical records and to improve communication with all the health stakeholders, adequate resources, financial, staff, medical equipment, medical and soft skills, capacity building and experience sharing initiative to support PHC facilities at all the stages of implementation, and introducing and developing population management tools to support managers to monitor effectiveness of its facilities. What is our future plan to implement? Because the Minister of Health decided to implement this model to the healthcare system, but taking under consideration the findings and the results, the Minister of Health established a team represented all the stakeholders to prepare a recommendation for changes in primary healthcare based on the PH plus pilot outcomes. They recommended to implement into the integrated care model voluntary and gradually by each facility in accordance with its capacity and business model. So the first step of implementation this model to the healthcare system will be implement disease management program, administrative coordinator of care and bundle payments, so the new way of paying for the services, and it became now. It started now in the third quarter of 2022 year. The next step will be implementation of e-tools supporting process of coordination. So individual medical care plan. It will be at the end of this year, and next year they implement the second intervention, which was piloting in the model. So it is health risk checkups program, implementation of e-tools supporting process of coordination. This health risk checkups program, its health checkups questionnaire, and individual healthcare plan, and it will be for next year. These are main information about the implementation of the coordinated care to the Polish healthcare systems. If you are interested in more details, please don't hesitate and contact me or the dedicated email address koordynowane@nfz.gov.pl. Also, as I mentioned before at the communication slides, we have a website that we dedicate to the coordination of care, academia.nfz.gov.pl. You find there further information about the project reports and all the information needed to widen the knowledge of this pilot program. So thank you very much for your attention. I hope see you soon in the ICIC conference, where you can ask a question if you need some more information about the project. I will be there. So